Today, the 7th meeting of Calicut Surgical Club. We have 3 academic programs. The PG topic will be delivered by Dr. Ashwant from Malabar Medical College. Then secondly, we have the senior faculty talk by our own dear Rajan sir. And the main topic of discussion today by thoracic surgeon Dr. Viniraj. So I invite all of you once again to this edition of Calicut Surgical Club, and I invite our secretary Dinulal to present minutes of the previous meeting.
Good evening all. The minutes of the previous meeting. The previous meeting was held on Friday 26th of June 2026 at Gokulam Grand Hotel with approximately 70 members in attendance. The meeting commenced with a welcome address by this President, Dr. Arunas. Following a silent prayer, the Secretary presented the minutes of the previous meeting. This was followed by PG presentation by Dr. Jasna from KMCT Medical College on a topic malignant melanoma. The senior faculty session was delivered by Dr. Madhav Nambiar sir, who shared his rich experience from his surgical career, reflecting on how his professional journey shaped his personal life and the challenges he encountered during the early years of his career. The main academic lecture was delivered by Dr. V.K. Pradhavan on relaparotomy, indication, timing and courage. The session was highly informative and was followed by engaging and interactive session, discussion from the floor. The meeting concluded with the national anthem, followed by fellowship and dinner. May the minute be passed. Thank you. Without any further delay, I invite Dr. Ashwant to present the PG topic.
Good evening, respected faculties. Thank you for giving me opportunity to present in Calicut Surgical Club. Here I am going to present a case of acute abdomen unmasking Crohn's disease. The patient was 22-year-old male patient who is a nursing student, came with complaints of abdominal pain and vomiting for 2 days. History of presenting illness. The patient was presented in the ER with a sudden onset diffuse, severe, continuous, sharp abdominal pain aggravated by movement. The vomiting was, there were 6 episodes of vomiting which was non-bilious and containing undigested food particles. There is no history of fever, GI bleed, abdominal distension, loss of weight, loss of appetite, altered bowel habits. There is no past medical or surgical history, and the patient having normal bowel and bladder habits with no substance abuse or addictions. There is no family history. There is no history of any GI pathology in the family. Physical examination. Patient was moderately built and poorly nourished. No pallor, rectus, cyanosis, clubbing, lymphadenopathy or edema. Height was 166 cm. Weight was 48 kg. BMI was 17.4. The vitals at the time of examination was 108. Pulse rate was 108 per minute. BP was 60/40 mm per mercury. Saturation was 96% in room air. Respiratory rate was 20 breaths per minute. Examination of GI tract and other systems. Oral cavity, there was no oral ulcer. Oral hygiene was good. Per abdomen was distended with restricted abdominal movements. Diffuse tenderness was present. Guarding rigidity was present. Bowel sounds could not be made out. External genitalia within normal limit. On PR examination, there was no blood staining. Other system was within normal limits. Initial differential diagnosis was generalized perforation peritonitis, duodenal ulcer perforation, appendicular perforation, or typhoid ileal perforation. Investigation and lab reports. Total count was 25,200. Neutrophils was 95.2%. HP was 12.9. Platelets were 8 lakhs. Sodium 126 milliequivalents per liter. Potassium was normal. Creatinine normal. Vital test was negative and CRP was 32 milligram per deciliter. The X-ray abdomen and chest showing the gas under diaphragm. The patient was initially resuscitated, rails tube inserted, IV antibiotics was started, catheterization done, IV crystalloids given. Patient was immediately shifted to OR and underwent diagnostic laparoscopy. At the time of laparoscopy, the findings were purulent collection noted in the pelvic and right iliac fossa. There was multiple ileal perforation seen. Procedure was, due to these key findings, the procedure was converted to exploratory laparotomy. Intra-op findings were, there were multiple perforation at a distal ileum, 20 cm from ileocecal junction was noted. Diseased 50 cm of ileal segment was resected and ileo-ileal anastomosis was done. On post-operative day 6, patient there was pus present on the drain. Lab values showed leukopenia and antibiotics was escalated to meropenem. On post-operative day 7, the first CCT was taken, showed dilated proximal bowel loop with a gradual transition at the anastomotic site, moderate ascites and bilateral moderate pleural effusion. At the time, the HPR report came and the specimen showed cobblestone appearance. Then another specimen showed the mesenteric creeping of pad of fat. The cut section of the same specimen showing transmural bowel thickening and cobblestone appearance. These are the multiple cut sections of the specimen. And the slide showing transmural inflammation with the ulcerations and granuloma with the multinucleate giant cell. The impression of the HPR report was severely active chronic Crohn's disease. Clinical progression on the postoperative day 9 to 13. Patient showed good response with meropenem. Abdominal drain was removed and patient was mobilized and started on oral diets. On postoperative day 13, patient was clinically deteriorated and a feculent discharge was seen at the drain site. There was no history of fever, abdominal pain, guarding or rigidity. Then the NPO status was reverted and CECT abdomen was planned. The second CECT, the finding were mild mural thickening and edema at the anastomotic site, luminal patency maintained, moderate ascites and loculated intra-abdominal collections was there. Due to the feculent discharge from the drain side, we did an relaparotomy, and findings were there were huge feculent collection in the left subphrenic and pelvic regions. Findings confirmed anastomotic leakage with multiple distal perforation to the anastomotic site. A large portion of small bowel remained unhealthy. 50 cm of the unhealthy ileum was resected distal to the anastomotic site and double barrel ileostomy was created. Post-surgical recovery. Initial patient was management in the the patient was on ventilatory and inotropic support. Then it was tapered to NAVP, BiPAP and finally to the room air. And on postoperative day 16, patient clinical condition was improved and shifted from ICU. Oral diet started and meropenem was discontinued. On postoperative day 22, identification of the surgical site infection, patient, it was managed conservatively. On postoperative day 31, patient condition, he was hemodynamically stable, stoma was functioning, soft diet was tolerating, surgical wound under regular dressing, and patient was planned for discharge. And planned discharge was planned initiation of biologic therapy after complete infection control. Final diagnosis, severe fulminant penetrating ileal Crohn's disease, presenting with multiple ileal perforation, generalized fecal peritonitis, septic shock, postoperative anastomotic leak, recurrent perforation requiring relaparotomy and double barrel ileostomy. This was the postoperative image of the patient at the day of 50. His BMI was reduced from 17 to 8.3. Then discussion. Crohn's disease. It's an inflammatory, relapsing inflammatory bowel disease with a transmural inflammation, presence of a skip lesion, and any part of the GI tract can be affected by Crohn's disease. epidemiology 15 to 35 peak age is 15 to 35 years. Genetic and environmental factors are there. Smoking increases the risk of Crohn's. The genes which are responsible are NOD2 and CARD15 gene. Immune dysregulation, gut microbiota, environmental triggers. Pathophysiology, there is transmural inflammation, cobblestone mucosa, fissures, granuloma and strictures are present. Clinically, patient will present with diarrhea, abdominal pain, weight loss and perianal disease. Investigation, blood investigation, stool calprotectin, colonoscopy, biopsy, CT or MR enterography. Complications, stricture, fistula, abscess, perforation, malnutrition. Management, managed with the steroids, immunomodulators, biologic and surgery if complications are present. Thank you.
It's been a great presentation. Just want to find out one thing from you. You have seen a case of very severe, acute, fulminant Crohn's disease in a very advanced stage. Did you at any stage give a history of previous illnesses pointing out to this particular disease? Was he ever treated by a physician for irritable bowel syndrome or any such disorders before he reported it with an acute complication of Crohn's disease?
No, sir. It was the first presentation. The patient was presented with the same complaints at the first presentation.
It's not usually that way, because as you already mentioned, it's a very chronic idiopathic inflammatory disease. It has got a genetic predisposition to it. You're not born with it. It has been found recently and quite for so many years that people who have a genetic lineage which is identical, who stay in rural areas and who migrate to urban areas, have more of a preponderance of irritable bowel syndrome and such disorders, ulcerative colitis, Crohn's disease, IBS, etc. This is a disorder, if you can pick up early enough, can be palliated, or even the complications can be postponed to several years. As you already mentioned, that the gut microbiome complex, alterations of it, is a major factor in the initiation of this disease. A genetic predisposition doesn't mean that it has to manifest as a disease, fulminant disease later on. It all depends on the environment you live in, the diet you take. These factors do contribute greatly to this particular disorder. And in the people who have the same genetic lineage who migrate to urban areas, the urbanization has an increased risk of all irritable gut syndromes, all the ones you mentioned. And they can be managed considerably safely by instituting therapy on that sort. It has been located that urban people whose ancestors were living in the rural areas still, they have a megamonas bacterium located if you are subjected to the current day fast food culture, processed food culture. And if you can suggest to these people that you avoid all these things and find the level of cytokines in their blood, which is an indicator of autoimmune disorders, it can go a long way in avoiding complications of it later life.
What is Monreal grading? Monreal grading of Crohn's disease.
Age for Crohn's disease, A1 means age less than 16 years, A2 is 17 to 40 years, A3 is greater than 40 years. Then B1 is ileal, B2 is ileocolic, B3 is colon.
And L1, L2, L3, L4.
Have you already started giving?
One more question. You mentioned some examiner may not like that. You mentioned that examination of GIT. The presentation, better say examination of abdomen. Okay, a good presentation.
He was tolerating oral after the surgery, ma'am.
After you have
TPN was given, ma'am. Total parental nutrition was given.
what biological treatment has been tried or planned to be tried in this patient? Any medical line of treatment?
Yes, sir.
Yeah, especially this very complicated case. Do you think that with your surgical maneuvers and you will be able to cure the disease? Do you think? And what is the status of the patient now? Is he improved or is he being cured, or do you expect more complications? Or do you want to treat with biologics?
We want to treat with
Immunotherapeutic agents. And what immunotherapeutic agent is there still being tried or planned to be tried?
biologics such as TNF alpha inhibitors can be given. Adalimumab, infliximab we can given as biologic agents. Then in severe cases surgery is the only treatment with the biologics we can give in severe cases. Also with that we can give steroids, then immunomodulators such as azathioprine, cyclosporin which can be given. Then 5 aminosalicylic acid, that is mesalamine 4 mg, 2 to 4 mg per day can be given.
You have tried it in this patient?
No sir.
Not being planned,
It was on our plan, sir. It was not right.
Okay, very good.
We can go with the ileostomy, madam.
So, what was your on-table diagnosis actually? See,
On-table diagnosis was multiple ileal perforation was there.
due to what? What is the reason?
That at that time we didn't.
And you mentioned in the pathology report there were creeping of fat is there.
Creeping of fat is there, sir.
That is in the pathology specimen.
Yes, sir.
So
There was mild creeping of fat was
see
there.
during the surgery.
No, sir. We
You
didn't.
cannot look for it. Maybe.
We didn't make out that, sir. We
So
cannot
what are
make
the causes, usual causes of ileal perforation?
out. Tuberculosis, typhoid, perforation will be
So
there.
how do you differentiate this clinically? I mean during surgery. Actually.
During surgery, in Crohn's disease, there will be mesenteric creeping of fat. Skip lesions were there.
Actually, this patient was presented with perforation peritonitis, and we never thought of this Crohn's disease. And so we present this case for this club because it's first time a Crohn's disease presenting as perforation. Perforation is a well-known complication of Crohn's disease, but this patient did not have any symptom at all prior to the admission. And on table we had found out this particular multiple perforation, but we did not suspect Crohn's at that moment because the creeping fat and all was actually identified by the pathologist, and macroscopically we didn't find any significant fat infiltration at that time. So we did a resection and sent the specimen for biopsy. At that time we did not cut open the intestines because for these typhoid perforation we usually do not open and see what's inside. We sent the patient for the histopathology examination. And before we did the second procedure, the biopsy report came as Crohn's disease. And when we reopened, we found that the intestines were thickened and the mucosa showed similar changes. So we did not attempt to re-anastomose because patient's condition was very bad and we could not afford to have another perforation after the anastomosis. So we thought of making a mucous fistula and ileostomy, and that worked out. So probably because of that, patient finally he had a very stormy post-operative period, but he managed to survive. And recently he has been admitted back and the ileostomy was reversed only 1 or 2 weeks back.
Are there any new therapeutic options in Crohn's disease, the newer ones?
Normally we did not start any biological because the gastroenterologist wanted the entire sepsis to be under control. Only after controlling he suggested biological. Suppose we start biological, patient may go for promote septicemia and may lose the patient. That's why declined to start the biologics.
For the postgraduates in this group, I would suggest that look into the newer version of a gut microbiome transplant. The fecal microbiome, freeze-dried crystallized forms are available and marketed by the FDA, an oral capsule to be delivered specifically to sites of intestine and colon. You will have another way of approaches to the colonoscopy and the gut microbiome transplant. It has been found to be pretty effective. 2 methods of approach, they are both approved worldwide, and we do not know when it's going to come to our part of the world. Your poof has a value. Healthy microbiomes can be cultured and prepared in such a way that they can instill into terminal cases or even people who are on the line of developing complications of it. It's going to have a wonderful effect, as people say. Okay.
Thank you for the active discussion from the floor. Thank you, Ashwin. Today, for the senior faculty talk, we have with us a great personality, an outstanding surgeon, and a mentor to generations of surgeons across the country, the one and only Professor Rajan sir. I first heard his name many times during my postgraduate training at Calicut Medical College from my unit chief, Professor Srijan sir, who always spoke about him with great respect. Rajan sir belongs to 11th batch of Calicut Medical College. He was the gold medalist of his batch, not only in surgery but also anatomy and pathology. He completed his MS in general surgery from Calicut Medical College and later obtained his FRCS from Glasgow. He joined the teaching service in 1976 and retired as professor and HOD of general surgery department in 2005. Even after retirement, he continues to contribute actively to surgery and medical education. He has delivered many prestigious orations, published several papers, and given numerous academic presentations. Some of his notable honors include the Alumni Oration and Dr. Raghavajari Oration. Apart from the surgery, his passions are teaching and cricket. In fact, once he missed the opportunity to be selected for the Kerala Ranji Trophy team because of his final MBBS examination. He has also served as a secretary of ASI Kerala chapter and National Governing Council member of Association of Surgeons of India. So it is our great honor to welcome you, sir, to present the moments of pride and lessons of pain.
Generally, I make extempore lectures. Thank you, Calicut Surgical Club, for inviting me to deliver this prestigious talk. Thanks for all the compliments that you have bestowed on me. I became a surgeon by design. I wanted to be in the medical side. I wanted to become a doctor, become a teacher when I saw one of the greatest anatomy professors, and when I worked with one of the greatest surgeons of Calicut, I thought that one day I should become a surgeon as well. And God was kind to me that I became a surgeon. So whatever he had been talking about, I thought that I have written down after a lot of thoughts, doing an introspection of what can go through the minds of perhaps most of the senior faculty members by the time they are hanging their white coats or boots or whatever you call it, and say adios to the surgical aspect or the faculty of surgery. In medical school, success means going into residency program. You want to become a house surgeon as early as possible. Of course, naturally you will take a minimum 5 years. Some people take a little more than that. It is part of the medical curriculum and medical life. So residency is the first thing that we always look for. And during residency, we probably would like to will get infatuated to certain topics or certain subjects, and perhaps it is initiated by our own teachers or professors who probably influence you greatly. I believe I too have influenced many of my wards to take up surgery, and some of them are super specialists as well. As a young consultant, I would say I never thought that I was a consultant till I perhaps put in about 10 to 20 years of service. And to be professor, one has to be proficient. That's my belief, that you should be proficient in subject. In academic subject, the whole thing was, success was in publishing papers, speaking at conferences, and becoming a professor. At every stage, we were chasing something which was ahead of us. We look at something and we keep on chasing. It is almost like chasing the horizon. You keep on walking to the horizon, you find that the horizon is a little more further and further and further. You hardly reach the horizon. And that's what is medicine all about. You will not reach the end of it. It's developing very rapidly is developing, that phase with which we can't keep up with every aspect of medicine. We thought of doing further learning, further degrees, and the next promotion perhaps. That's all perhaps in the academic side of it. I wouldn't say that the entire group of surgeons will go straight away into academics. Many of them are into practice, perhaps. And I always ask students, how many of you would like to become a teacher? Maybe 1 or 2 hands will come up on the first day, and by the time final year, none of them want to be a teacher. For years, I believed that fulfillment was waiting at the next milestone. And the milestone kept on creeping forward. So I found out that medicine has no finish line. It's a continuing process. There is no final award that makes you feel complete. No designation that silences all doubt. No accomplishment that finally lets you say, now I have arrived. If I could go back and speak to my younger self, I would tell them, all the guys sitting there, slow down. Don't be on a rocket straight away. Slow down, learn well, and you are missing the best parts of life as you start developing into from a budding surgeon, the metamorphosis into a consultant, no matter whatever you call, right? The best part perhaps one in our life will come across with a patient with folded hands or with tears in his eyes because you gave him hope. You gave him hope when everyone else had given up. Like this boy was presenting a perforated ileum. It was a hopeless situation to begin with, but over a time, the hope started coming in. Of course, it took a long time, but never mind. But that is what we are. And the mother who smiled after hearing her child would be okay. These are the best parts of our life, perhaps. The student who walked into our office or into our classes, often unsure of what is going to happen themselves, they walked out believing they could become a great doctor one day, sometime earlier, sometime later. A resident who called years later just to say, "Sir, I still remember what you taught me." I think that is the greatest thing I have probably acquired in my life. Being a teacher, and particularly, I would say Calicut Medical College. I have worked in other medical colleges as well. But then being a teacher is perhaps one of the best things that can happen to you. And that's why I always ask students, would you like to become a teacher? The night duties that left endless. I'm sure many of my colleagues, and when I had been an assistant professor sitting together in the emergency department, the night duties that we were doing were really academic, fun-filled, tense. Sometimes it was tense period, definitely. But then the research that we brought out was really fascinating, really adorable sometimes. The difficult cases that kept you awake at night and the joy when a patient unexpectedly recovered. I think that is one thing gives you a great joy in your life. And the quiet cup of tea or faluda or the badam milk, which I used to give them all the time after our night duty, was always a refreshing, and everybody relished it. And I think the most important thing is the privilege of holding someone's hand during the most vulnerable moments. That is something that we had done. Those were never distractions from the journey, because you had an aim, perhaps, to occupy a post, to do something for the society. And this was a journey. Over a time, what happened is the degrees get dust. The awards fade into cupboards. The publication becomes numbers in your curriculum vitae. But decades later, what remains are faces. The faces you taught, the faces you treated, the faces perhaps those who would have probably with arrogance would have met you on various occasions. Today, that part is perhaps on the rise. People facing you with arrogance rather than gratitude. Because my professor used to say, "Rajan, never expect gratitude from your patient." But I'm sure many patients are still very grateful for whatever you have done in the sojourn of their life and in our sojourn. The students who became teachers themselves, the people who carry a small part of you in them. That's what I love. That some of our subordinates became teachers and started contributing to a great extent. Srijan is a classical example. The milestones will keep changing, but the moments of compassion, learning, healing, and human connection, those are the things that's going to stay. There's only one more page. I put in a long way, that's all. I'm sorry if I'm taking a little more time. And finally, when the white coat is hung for the last time, you won't remember any award, every award that you have won. You will remember the lives that crossed yours. And you will realize that success was never about becoming a great doctor. It was about being present for thousands of lives, thousands of small moments that made a difference. And what a privilege that was. One day you will see that the patients were never just part of your career, they were part of the story of your life. So I always give credit to the college, to the teachers, to the students who made me think, and to the patients who taught me beyond the books. Many things were perhaps not written in the books, and the patients have taught me most of the things. To make the thing a little, I will just present one case. At a time when I'm sure Madhavan is the only candidate who can remember that particular patient. It is a saga of an empyema thoracis. One of the great professors operated upon our patient who came with hematemesis, a prehepatic portal obstruction. The surgery that was done. There were hardly any investigations or any scans we could do those days. He took him up for surgery, did a huge thoracoabdominal incision, did a splenectomy and a modified Tanner's. Perhaps the present day students may not even have heard of Tanner's. The modified Tanner's was cutting the anterior wall of the stomach, ligating the mucosa inside, and then suturing the just producing a portosystemic disconnection. That is the whole idea about it. Things went on well till about the 7th, 8th day. He started developing fever, very high fever and toxic features, and the only antibiotic at our disposal was perhaps penicillin and streptomycin, nothing beyond that. Not even gentamicin was available those days. Anyway, he developed a right royal empyema thoracis, and there started his story. Poor fellow. We used to sit and Madhavan is starting to laugh. It's not a laughing matter actually for the patient. We used to sit and aspirate his empyema when it was thinner, and it started becoming thicker. So the next we got to the next stage. It's not stopping and it's continuing. So the next stage, I'm here, the thoracic surgeon sitting here. We did a ribresection drainage for a better, wider drainage. It didn't stop there. He went in for a thick walling of the empyema cavity, and there, by the time we had a thoracic surgeon in our hospital, and I was working with him at that point of time, and we did a decortication. It's one of the most difficult surgery and a horrible surgery, I would say, bleeding till the lung starts keeping expanding. And the professor, out of curiosity, started lifting his drainage bottle and the whole way back into the pleural cavity. The professor of thoracic surgery was really upset about it, and the infection was there to be present. What shall we do? It's not the cavity is not collapsing, and the final part of it perhaps was an anterolateral thoracoplasty. I'm sure the thoracic surgeon sitting here would say that that is a saga of an empyema. This person is now a big Congress candidate. He came to visit me. He is Kelappan from Kelagam. Right. I'm sorry that I made his identity open, but then one of those days he came to visit the professor in the OPD, and one of our junior surgeons, he was doing his postgraduate studies, and that is the only funny climax of it, or I would say anticlimax of the whole situation. And when the postgraduate student was sitting with the professor, he lifted the shirt of this patient and said, "Come on, have a look and tell me what it is," because he has got a collapsed chest wall, everything. But this poor guy was looking only at the total number of scars. Then he said, "Sir," he said, "post-Burns contracture." That is the anticlimax of a person who has gone through the hassles of so much from aspiration to thoracoplasty. Right. Thank you very much for giving me this short time to share my experiences, particularly as a teacher. And this particular case, which always I keep remembering, because there's one case which I had followed up That's right. Boyd said that you follow up your patient up to the graveyard. This guy is still alive. So I can't do that at this moment. Thank you very much.
Thank you, sir. Today's academic session has been planned primarily for the benefit of the junior surgeons and surgical residents. In emergency department, we frequently encounter the patients with chest injuries. In many cases, our initial management is based largely on the experience and practical knowledge passed on by the seniors. However, we never ask ourselves whether our approach is fully aligned with current evidence and best practices. Is every chest injury best managed with intercostal chest strain, or are there any situations where different approach is more appropriate? To provide the clarity on this topic, we are privileged to have with us a young dynamic surgeon, Dr. Dinraj, consultant CVT surgeon, Aster MIMS Calicut. Dr. Dinraj completed his MBBS from Pariyaram Medical College, followed by MS General Surgery from Amala Institute of Medical Science, Thrissur. Then he pursued MCS of Cardiothoracic Surgery from Seth GS Medical College and KM Hospital, Mumbai. Further enhanced expertise with fellowship in VATS, that is Video Assisted Thoracoscopic Surgery, from Yashoda Hospital, Secunderabad. Despite sustaining a leg injury, Dr. Dinraj made the effort to be with us today to deliver the lecture. We sincerely appreciate his commitment to academics and his dedication to sharing his knowledge with us. It is my great pleasure to welcome Dr. Dinraj. And to chair today's session, we are privileged to have with us I called Guryako sir also, Rajesh sir, Professor and Head of the Department Cardiothoracic Surgery, Calicut Medical College. We are honored to have you, sir. Welcome, you, sir.
So good evening, everyone. First, I thank Calicut Surgical Club to give me an opportunity to present here. I know this is a very a good opportunity for me to present one of my favorite topic here in front of the great teachers, seniors, and my friends. I am very passionate about trauma, and then I took thoracic surgery as my specialty after completing CTVS. I am not doing any cardiac work at present. So Rajan sir told about Empaima and the management. I never saw a thoracoplasty till now. I have heard about. I try to attend some workshops. It's happening very rarely nowadays, but I know the old procedures are still the one of the best bailout procedures. One is a window procedure and a thoracoplasty. I know I have 1 or 2 patients even now for thoracoplasty to be done at a later state. So from here I'm starting the topic. When Dr. Dinulal called me and asked to present the topic, I asked how much time I will get. It's very difficult to complete this topic with 30 minutes, but sometimes I'll run through the slides and I may not discuss chest wall stabilization if time is exceeding too much. So I'll be going through the introduction, then pathophysiology of chest trauma, evaluation, interventions, and Finally, I will end up with the ED thoracotomy procedure and surgical stabilization of rib fractures. So our patients may be like this: a car accident with multiple injuries, chest injuries, unstable hemodynamics, or maybe a history of fall with a penetrating chest trauma or something like that. But usually our patients will be unstable hemodynamics. So definitely we know these patients will be managed in ED by the ED physicians according to the ATLS guidelines. Definitely we will be part of the management. So what we have to very specifically look in a polytrauma patient, and what changes happened from previous concept and nowadays. That is why I'm going to discuss here. So thoracic trauma is one of the most common major trauma happening in our area, which causes contribute around 10 to 15% of all trauma patients and half of polytrauma patients. It can cause a direct death of the patient in a quarter of the patients, polytrauma patients. It can present in different way. It can be a hemothorax, pneumothorax, or a major injury to the thoracic organs. Coming to rib fractures, it happens almost 10% of all trauma admissions and 50% half of the blunt trauma patients. Most of them are treated conservatively, but the new technique of surgical stabilization of rib fractures can be advised to severely displaced fractures and flail chest. I will discuss it if time permits. In older adults and severely injured patients, this causes high risk for pneumonia or respiratory failure and death. Mortality is around 34% in patients with more than 8 rib fractures, as per the literature. So this is the pathophysiology of respiratory compromise in a polytrauma patient with chest injury. So when there is a thoracic trauma, there will be rib fractures, there will be pain. When there is pain, we will not move. I know how much pain will be there when a bone fractures now. This is first time I'm getting a bone fracture. So this I can immobilize, but chest, it is moving at least 20,000 times every day. So how much will be the pain? So when there is pain, we'll try to splint it by ourselves. This splinting causes shallow breathing, which impairs the cough reflex, which impairs the clearance action of our body. It causes atelectasis and secretion pooling, pneumonia, ARDS, and finally into respiratory failure. So we are able to compensate all these problems or recover from these problems by our newer technologies. Coming to thoracic trauma, these are the presentations usually. Hemothorax and pneumothorax are the most common presentation, along with pulmonary contusion. Pulmonary contusion is one of the intrathoracic pathology in trauma which we neglect almost every time. The problem with the pulmonary contusion is when there is a contusion, injury, our body tries to pool blood in fluid in that area. So, and our routine technique is when there is a trauma, when there is a hypovolemia, we try to push more blood, more fluid. So all this fluid, excess fluid, will pool into the chest, and which in turn leads to ARDS type of picture. Cardiac injury and aortic injuries are rare, but these are very lethal. We have already presented 2 cases of cardiac injury 2 months back. So as I told, management will be according to the ATLS protocol. According to the latest 11th edition ATLS protocol, it is X, A, B, C, D, E, where X is the control of exsanguinating bleeding. So after stabilization of the patient, definitely the second step after primary stabilization of the patient, next step is investigations. So EFAST and chest X-ray are the available investigations in ED, which are portable. So we can do it early. But the problem is EFAST can identify thoracic collection, pneumothorax fast. So when the patient is hemodynamically unstable and there is pneumothorax, we can suspect a patient that patient is of a tension pneumothorax and put an ICD without even going for a chest X-ray. So that is evidence. Evidence is there, then we are intervening. Previously, we were putting an ICD based on the clinical finding. So EFAST and chest X-ray is fast and which gives idea. And next is CT thorax. When the patient is stable, after the patient is stable, we can go for a CT thorax. Ideally, it should be a CECT thorax. And if there is a upper rib fractures or clavicle fractures, we should go for a CT angiogram to rule out any intrathoracic or neck vessels injury. After all these things, you have a tension pneumothorax. When there is a tension pneumothorax, you should definitely evaluate for a major airway injury. So you can go for a bronchoscopy later to identify there is a airway injury or not. If you are suspecting a esophageal injury, you can go for a OGD-scopy also after stabilizing the patient. Then finally, VATS. When there is a suspicion and you don't have any evidence from the image, like there is a diaphragmatic injury or some other persistent air leak without any evidence for lung laceration or something like that, you can go for VATS. So it's not VATS, it is an exploration. So coming to the topic, when to do each intervention. What are the interventions and when to do each and everything, each procedure. So first thing, we know we were doing ICD for all the patients who are having a pneumothorax or a hemothorax in the ED. We know the indications for ICD in general, but when it is trauma, according to the ATLS guidelines, any symptomatic pneumothorax or hemothorax is an indication for ICD placement. We can wait in some conditions. I will specifically tell there is a slide coming for the when to wait, but still, if we don't have a reliable monitoring system, we should do ICD for all the patients whom we are suspecting an intrathoracic injury with a hemothorax or a pneumothorax, and definitely after any thoracic procedure. So these are the landmarks. This all we know. This is the safe triangle, and left side is an indication, the landmarks for doing a emergency needle thoracostomy for tension pneumothorax. It is in the second intercostal space in the mid-clavicular line or in the fifth intercostal space anterior to between the anterior axillary line and mid-axillary line. So I'm not going into this. I'll highlight only one point. Antibiotic prophylaxis is necessary for an ICD procedure because it is the simplest thoracic surgery procedure. It should be given, ideally gram-positive coverage should be there, and it should not be carried after 24 hours. This is the sucking wound. When there is a large wound with a flap of tissue, which causes, when the patient inspires, it sucks air inside and trapped inside. Because of the tissue flap will close the wound when the patient expires, and it will cause a tension pneumothorax in the progression. So this such wounds should be dressed with a 3-way occlusion dressing, and immediately, if possible, put an ICD in that site. So before transport, this patient should we should put an ICD on that side. And it should not be through the sucking wound. It should be a separate wound, because sometimes this sucking wound will be having this wound will be having some clot inside, which will be compressing the vessel and preventing the bleeding. So when we can wait when there is a mild pneumothorax or mild hemothorax, and when we have a reliable monitoring system. So if we have a patient with a pneumothorax occupying less than 20% of the chest cavity in the X-ray, or less than 3.5 in the CT, or a hemothorax less than 500 ml, we can conserve the patient. We can see how the patient is progressing by taking an X-ray within 6 hours after the admission. So next is opening. Tube is over, weight is over. Some case we have to open our patients. So what are the types of opening? One is an ED thoracotomy, which is an emergency or immediate decision making. Next is an immediate opening, where we have some time to shift the patient to OT, or early or urgent or early intervention, which is we have some time to take the decision making or to take the investigations. So in case of immediate, we don't have a sometimes we won't have a time to do a radiological investigation. So these are initial drain more than 1500 ml or ongoing bleeding of 200 ml per hour for 2 to 3 hours. Hemodynamic instability with a worsening stroke, with a penetrating injury requiring multiple ongoing transfusions, and suspected cardiac injury or tamponade are the indications for immediate opening. Shift the patient to OT and open the chest. It can be a thoracotomy or a sternotomy, or sometimes a sternothoracotomy. But urgent or early intervention, we have time. Hemodynamically stable patient, we can shift the patient to CT scan, can do a contrast enhanced CT. We diagnose there is some problem, there is some persistent air leak is there, sometimes some patients, diaphragmatic injury is there, sometimes hernia is there. We have time to repair such patients. These patients can undergo a video assisted minimally invasive surgery, which avoids a large thoracotomy, which will in turn, if it is a large thoracotomy, pain will be there, the patient's mobilization will be delayed. So in such patients, VATS can be a option in such patients. And surgical intervention, early surgical intervention can be advised in patients with multiple rib fractures. This is a algorithm for based on the ATLS East and West guidelines for thoracic injury exploration. When there is a massive ongoing intrathoracic hemorrhage, an emergency thoracotomy, if the patient is stable, we can go for an early VATS. These are the evidence. One is from Texas and the other one is from Taiwan. There are so many papers from different part of world coming up with the evidence for VATS in early VATS in hemothorax, retained hemothorax, and multiple other procedures in case of thoracic trauma. So it should be done within 3 days or 4 days, which gives better result in the patients, which decreases the hospital stay, ICU stay, ventilator requirement, and decreases the chance of empyema and So next is ED thoracotomy or a resuscitative thoracotomy. It is not done routinely, but it is previously it was done for even a massive hemothorax and all. But now the indications changed because we have our new technique to overcome the bleeding and hypotension. So ED thoracotomy is indicated only when the patient is arrested to revive the patient. So now it is called resuscitative thoracotomy. When the patient is in front of you going for an arrest, peri-arrest situation, we don't have time to shift the patient to OT, then we can go for a ED thoracotomy. What is the approach for ED thoracotomy? That is an anterolateral thoracotomy, which can be extended to a hemi-clamshell or clamshell, because you can extend your exploration to opposite side also. So after after doing an anterolateral thoracotomy, first we will evaluate the pericardial cavity by opening it vertically. If there is any tamponade, if there is a cardiac injury, we can repair it. Then if there is a peripheral wound which is bleeding, now it is not actually a big issue, big problem, because we can use a tourniquet. We have other techniques also. Even though Ribova is not available in India, but the technique is the Ribova is a balloon, aortic balloon, which prevents lower limb bleeding, torrential lower limb bleeding or abdominal bleeding. So in such case also, when there is an abdominal bleeding or a lower limb bleeding, you can clamp the aorta in the thorax by doing a resuscitative thoracotomy, which will increase the pressure in the upper extremity, especially protecting the brain. So for doing a ED thoracotomy, you need a very good team, including a trauma surgeon or a thoracic surgeon in the ED setup. So the last topic, if you permit, I will finish this also. Rib fracture. What are the current guidelines? It is not a new thing. Rib fixation is not a new thing. It is happening from age-old, 2000 years ago. Even Roman surgeons, Soranus did the rib fixation, rib excision in case for a pain due to fractures. These are the previous techniques used for a flail chest fixation on the left side. It is very crude technique, holding the sternum with a towel clip like thing and pulling it upwards and fixing it to rods, stabilizing the chest. Another one is percutaneous rods, which is stabilizing the chest wall. But everything changes. Our seniors were using Chetak bike, Chetak scooter and all, or Maruti 800 previously. Now we all are using BMW and newer vehicles, so we have to update. So this is the timeline of stabilization plates available. Now we have very good titanium plates with screws available, which not to be removed after stabilization. So the classification, different types of rib fractures are undisplaced, offset fractures, or displaced fractures. I told this is not a new thing, fixation of chest rib fractures, but indications are actually changed a lot. When I started in 2022 the rib fracture fixation, we were following the 2017 guidelines where 4 or more rib fractures are there or flail chest to be fixed. But now it is changing. Even more than 2 fractures are to be fixed if it is unstable or displaced. And when there is a deformity of chest wall instability is there, when you are getting a clicking sound when you are pressing, it is an indication for chest wall fixation. And severe pain is an indication if the patient wants to fix it. There is a terminology called pulmonary derangement. It includes tachycardia, poor cuff reflex, reduced ventilatory capacity, that is incentive spirometry less than 50% of the predicted, or pain score more than 5. So there are some contraindication, but these are not definite contraindication. Only one definite contraindication is a SSI score 75. That patient is dead. All other case, we can stabilize the patient. If the patient is improving, we can go for a surgical stabilization of rib fractures, because even in severe traumatic brain injury, if you can do a chest wall stabilization, which reduces the risk of pneumonia, ARDS, which improves the patient oxygenation, which will reduce the brain secondary damage due to hypoxia. So that there are papers on this topic also. CT with the 3D reconstruction is the ideal investigation before going for a chest rib fixation. Definitely X-ray X-ray can give you idea, but it gives it can't give a definite idea how it is displayed. Sometimes it will give a less information than CT. Whether you have to do VATS in all patients, no, it is not indicated. Only if there is a retained hemothorax or a suspected intrathoracic injury, you can go for VATS in such patients. And bone grafting can be advised in some patients with segments which are displaced more than 1 centimeter. But I never did a bone grafting in such patients. We usually remove a large chip of bone which is projecting into the cavity. It will not give it will not cause big problem in even though it is a 1 centimeter chip. Surgical approach, you have to go for a muscle sparing technique. Muscle cutting technique is not advised currently because it will give more pain to the patient. Patient will be more bedridden or need more rest than a conservative management. So now we are almost all the surgeons are doing a muscle splitting technique, muscle sparing technique, and a minimally invasive techniques. You need to put multiple incisions, but the full thoracotomy skin incision is not needed for doing all rib fracture fixations. Previously, alternate rib fixation is advised, but now all the rib fractures to be fixed. That is the current Chest Wall Injury Society guidelines. And timing, if you can do it within 24 hours, that will be the best result. But anything done before 3 days will give better results than a conservative management in case of multiple severely injured rib fractures and flail chest. So this is a large meta-analysis with including more than 35,000 of patients showing definite improvement in the results with the surgical stabilization of rib fractures in polytrauma patients. It says it reduced the mortality, ARDS, and shorter duration of mechanical ventilation in patients with multiple rib fractures. So this is a multiple short videos on the different steps. Here after incision, after splitting the muscle, identify the fracture segments, reduce it with the reduction forceps, which is actually like a our towel clip. Reduction is done. Then adequate length plate is taken. Ideally 3 screws should be fixed on both sides of the fracture and one hole at the level of fracture. So ideally 7 hole plate. Then mold it accordingly to the contour of the rib. Then place it on the rib and fix it with a plate fixer. This is the plate fixer which holds the plate hole to the rib. Then drill the hole for the screw. Now there are screws available for without drilling directly. Self-drilling screws are available. Then apply the screw, which should not be too tight because titanium has a special property of cold welding technique property, which will weld the screw to the plate it will be difficult to remove the plate if something happens like empyema or infection happens. So this will be the final results. So take home message is tubes are not the last in hemothorax or any thoracic trauma situation. VATS can be a new technique in trauma exploration in stable patients. ED thoracotomy has its own new role of resuscitative role, and surgical stabilization of rib fracture is not a new technique, only its indications are changed now. Thank you for giving me opportunity to present this topic here once again. I am ready to answer any doubts, any questions on this.
Thank you, Dinulal, for that wonderful talk. The slides were very good. See, adding on to what you have said, more than 80% of these patients can be managed conservatively. That is the take-home message that what you was talking. So about 12% of patients need ICU care, and they can have complications within 3 days if you don't treat them properly. Like the cornerstone of any conservative management is analgesia. I understand many of the postgraduates are attending this talk. So pain management is absolutely important. So he has elaborated on the surgical management of emergency room thoracotomy in indicated cases, rib fixation. Rib fixation, as you need to understand that the randomized controlled trials support more than 3 ribs fractures. That is, a definite benefit has been obtained for these patients, and as if patients need, you can apply the techniques for less number of rib fractures also. But for basically for a standard scientific practice, it is better to use for more than 3 rib fractures. And the results are, you need to see for yourself. You put it, do it for 2-3 patients. We have realized the improvement in patient care. They just walk out of the room like anything. They do like any other normal patients the next day onwards. So it's a wonderful technique. And one thing is that the X-rays, as you need to see, these X-rays can really miss. You can miss X-rays in pneumothorax. It is said that in isolated single rib, 2 rib fractures and all, 50% of X-rays may miss the pneumothorax if you don't see properly. So residents, please use your stethoscope to see the air entry on both sides bilaterally, clear, very good, because that will save lives. Even if you have a suspicion of decreased air entry, then you go for a pneumothorax or an POCUS, point of care ultrasound is there, you can do it, and that way you train yourself. So that is about. And the underlying lung parenchymal injury, it's almost underestimated. He was elaborating in that talk, because that is what decides the outcome in a flail chest or a chest injury. So the underlying chest parenchymal pulmonary contusion management is also very important. You need to give chest physiotherapy and pain relief and proper ventilatory management also. If you need to give oxygen or a little positive pressure ventilation also is always great. And nothing much. He has touched upon almost everything. A word to add on to is the use of ECMO, extracorporeal membrane oxygenation. Especially if you are not worried about bleeding too much, you are flogging a tired horse when you add a patient or put a patient on ventilator who already has an ARDS or a sort of destroyed lung. So ECMO is an extracorporeal membrane oxygenation. This technique can be used for patients who are not doing well from the pulmonary parenchymal point of view, not from a bleeding point of view. You can have bleeding complications. So that is one thing that the thoracic surgeon can try in selected cases. Otherwise, all good. Nice talk. Anything else?
This slide actually I skipped. This gives a very. This is actually the management of rib fractures. Not rib fractures. It's actually thoracic trauma. Stabilize the patient, adequate ventilation, then ICD pneumothorax if required, and analgesia is the key point. Sir already told. NSAIDs, opioid, epidural. There are studies actually. Epidural is not necessary now because you can go for a continuous infusion into erector spinae. plane.
There is so many papers on this non-conservative management, like what he said, epidural, paravertebral blocks, erector spinae blocks, then serratus anterior blocks, so many types. Because in this era of ultrasound, no, you can point each muscle and each plane and put analgesia. So that also works very well. So
Excellent talk. I have a doubt whether you are over-treating the refractures. I have no experience treatment with the splint, etc. You over-treat one fracture or two refractures. You can consider very well conservative management. Very well, and over-treating.
For me,
I doubt to the Srijayan and Rajan Kumar whether you are in Calicut, but you are seen maximum number of trauma refractures. Are treating like this or just conservative?
sir, I did only 40 cases in last 3 years, because we treat only flail chest with the surgical stabilization initially.
Single refracture?
No, sir.
Second refracture? Any?
No, sir. I will not advise. Only if the patient wants, we can do it. I've seen surgeons doing it. There are papers on that also, sir. It will help only to control pain. No other benefits.
sir, as you said, the scientific practice supports only 3 refractures. Two RCTs have come. One is a ORIF trial and second is a non-flail trial. Both support only 3 refractures. Less than 3 you can manage conservatively, but as he said, if the patient needs, this is a technique that you have to see and believe, because once you put for 1 or 2 refractures also, they do really well. So that way you are over-treating patients, we agree, but depending upon patients' requirement of if their demand, we can put. Infection, if you have an already infected wound, this is not
This
advised.
high.
But otherwise,
No infection. It will be very difficult, sir. That is why I told these titanium screws have a special property of cold welding. So if you are tightening more without knowing this problem, then you will be screwed.
Mini plating. Mini plating.
Mini plating.
That's what we will do for facial fracture.
Okay, sir. Okay.
We have seen that few refractures, patient present with pain, we usually refer to anesthesiology for a intercostal block.
Intercostal blocks. These single rib, 2 ribs can be fixation can be done under local anesthesia also, sir. One under block also.
Another situation, single rib fracture, no pneumothorax, patient is not symptomatic, but on CT showed a projecting curtain inside the thoracic cavity.
It's a displaced fracture. Displaced fracture. It is. You can.
Exploration?
It's not an indication for exploration as per the guidelines, but you can do it, sir. That's all. If they want. The latest guidelines came from Chest Wall Injury Society. Is 2025 guidelines, which says more than 2 rib fractures, 3 or more rib fractures, displaced fractures can be fixed.
I think our political leader, Karunakaran, I think you may be remembering, all of us will be remembering, he was not happy with the pain management done here in Kerala, I think. And he went to states and to get relief of the pain. And probably had some this sort of intercostal block or even epidural anesthesia, I don't know. Anyhow, that was given and he was very much happy with the treatment there and he came back.
So there is a new advancement in thoracic analgesia technique. We can do cryoanalgesia techniques which give a long-lasting pain relief for such patients. So, but it is expensive. Recently, I think last 6 months only it got approved in India, got licensed in India.
Nice talk.
Thank you, sir.
Have you ever come across a first rib fracture?
Yes, sir. I have fixed only one case of first rib fracture which had a sternocostal distinction, which was actually causing instability of the chest wall, and patient was not able to wean off from the ventilator. So we did a first, second and third rib fixation.
Was it an associated vascular injury?
No vascular injury. We had cases with the first rib fracture and carotid injury, which caused severe stroke and also. So first rib injury is an indication for first rib or second rib injury is an indication for carotid angiography along with initial.
First rib fracture is actually a pointer towards the severity of injury. So as residents, if you get a first rib injury, always look into the great vessels, because and the wide and mediastinum and all. We have done 2 or 3 cases long back, not recently, with the subclavian. I think sir and you yourself all were there at that time. So we have done subclavian artery injury repair that time. 2 cases I remember.
Yes.
Brachial plexus also was involved in one case.
I had a case, that's what I was talking about. He was hacked. Axon to
Okay.
the clavicle, the first rib, and the subclavian. The subclavian vein, those days we couldn't do nothing other than ligate it. But the artery we repaired with sutures. Unfortunately, we had only 3-0 or 4-0 protein at that time, not 6-0 or anything. And anyway, he survived. And when the case came to the court, the material object that was kept for was a small penknife.
Recently, we had a case in MIMS. Young girl and husband were traveling in a bike and met with an accident. Both had thoracic injury. One had a diaphragmatic rupture and a diaphragmatic hernia, and the other patient, the female patient, was totally stable. But as a protocol, we took the CCT and found a aortic isthmus disruption, and the patient underwent endoscopic TAVR and recovered completely.
Another case that I remember was in the past and several years back. A boy was brought in the emergency casualty in Calicut Medical College. He was absolutely normal. He was with history of this firecracker injury, that is during the celebration of Vishu. And this boy was appeared to be very stable. And when he sustained injury on the chest wall, he was taken to the dressing room. Then we thought there is a fractured rib is there, which could be suspected. And he was sent to the X-ray. In those days, we didn't have any scan or anything like that. So in the X-ray, by the time this boy came back to the casualty, that he was dyspneic and breathing difficulty, and he was not in a very stable stage. So that means we are forced to do this thoracotomy in this patient. So thoracotomy, then he had a lot of blood in the pleural cavity. But the source of blood could not be identified. Even if when we opened the thorax, there is nothing. The source of bleeding not from the lungs or anywhere in the area in the neighborhood. But there is a feeling on the diaphragm that we could feel that this was on the left side. We could feel that some sharp objects could be felt on the diaphragm, and this incision had to be extended, and so that it is the foreign body, that metal was stuck in the spleen, and the bleeding was from the spleen. So that boy, when we had to proceed with the splenectomy as well, through the same wound, through the same thoracic wound and with extension. So this is a case, and with a repair of the diaphragm and suturing of the diaphragm, and the boy became absolutely well. In 7 days and 10 days, 7 days time, he could be discharged. It was a very interesting case, and still they came with a very simple and could be disposed at that time, but it landed up in the thoracotomy and still proceeded with the splenectomy, and the boy could be discharged with well cured.
In this
First rib as well as a floating rib, both are dangerous.
Dangerous.
If you have a fracture of a floating rib also, it's equally dangerous.
I have done one fixation for 10th and 11th rib because usually 11th rib we don't fix. This patient had a right renal injury along with complete separation of diaphragm from the costal margin. So we have to fix the rib and reattach the diaphragm to the chest wall. And in this slide I put a point, post-traumatic empyema. I was remembering one case, actually 12-year-old boy who was playing with his father in the work area and had an injury with an iron rod in the left lower chest. It was pulled out. When the patient came, it was actually a sucking wound. When we put the ICD, I was seeing some granule-like thing. So I was suspecting what actually happened. Sometimes it may be a rust or something like that. So I told we will open this case. Some ED people told no, it's not necessary, but forcefully we opened the patient and we found that there was a diaphragmatic rent. Then we went through the CT once again. The trajectory was actually just diaphragm, then it was going into the stomach area. Then the pediatric surgeon was called and did a laparoscopy. There was a through and through wound in the stomach and it got repaired. The inside of the chest was like a peritonitis picture. So it can also happen. When they pulled out the rod, the stomach came out and the opening was actually into the chest. One opening was into the chest through the diaphragm. So that was the cause of these granules. It was food particles.
Dhinraj, up to what grade of chest injury you can manage on OP basis?
Multiple rib fractures, up to 2 to 3 ribs. If the patient is pain tolerable, then you can manage OP basis if there is no hemothorax or pneumothorax. Ideally, if there is any hemothorax or pneumothorax, you observe the patient at least overnight. Make sure that it's not expanding. Then you can discharge the patient next day if the patient is pain is completely controlled and all. You can use multiple oral analgesic and Fenda patch or bupivacaine patch. You can even get lidocaine patch now and advise for 1 or 2 weeks, which will give pain control for that time. By the time it will start healing and pain will come down.
Thank you, ma'am. So I invite Mr. Vishnu to introduce the drugs of Aces Pharma. And our next meeting is scheduled on Wednesday, 19th of August. It will be a special Onam celebration meeting. We request everyone to attend the meeting dressed with the traditional Onam attire. We are planning to organize few fun games and friendly competitions among the surgeons to make the evening enjoyable.
Sir, എടുത്തോ. Okay, good evening all. So first of all, thank you very much Calicut Surgery Club team for this wonderful opportunity to part of this beautiful evening. It's a gathering of beautiful surgeons. It's the first time actually I'm attending a conference in Kerala. I'm in the pharmaceuticals field for last 10 years. I'm in Chennai. So actually my name is Vishnu. I'm taking care of entire Kerala as zonal sales manager. So we have some products actually. Actually, we are ISIS Pharmaceuticals. Some doctors already knows our company. So we are launched on 2015 in actually head office in Chennai, and we are covering entire South India. And we have 12 divisions, including cardiodiabetic, neuro, nephro, gastro, and including this our surgery department. And we have 891 employees working in this company as a families. So we have the fastest growing company in India in the last continuous 3 years. We have achieved some international awards also, and we are entered the top 100 companies in India with a short span of almost 10 years, and we are into the 3 billion company. So moving on to our products. So this is our flagship product. For the first time, we are launching this product for wound management. It's a combination of gentamicin in collagen base. It's actually gel form, so dual action, infection control and also tissue repair. So we have these products in 30 grams. It's a cost of only 249 rupees to the patients. It is very effective, and also we are getting terrific feedback for this product also. Please try it for some patients. You will get the very good result. And we have our next product is Veines for the treatment of CVI, varicose veins, hemorrhoids patients. It's a combination of citrus bioflavonoids along with rutin for lymphedema patients also you can recommend. So this is our second product. And moving to the third product, it's a beautiful combination of proteolytic enzymes, trypsin, bromelain and rutoside. We are not adding any NSAIDs into this. So we are adding naturally proven scientific for herbal extracts. We are adding in these combinations, and we are covering in surgery department. We are in the therapy for wound management. We are comparing these 3 combinations: icibrofort, Veines and Tiviogen. Icibrofort for anti-inflammatory support, and for Tiviogen we can use it as infection control and also tissue repair. And our third product, Veines for varicose veins and hemorrhoids. Put together this combination, we are getting good feedback from doctors. So kindly use this combination. And we have bile pass for ursodeoxycholic acid, 300 milligram, and Pufacto. It's a combination of omega-3 fatty acids with vitamin E. So these are 5 products we have for leading brands in surgery segments. Please kindly support our brands. Thank you very much, sir. And once again, thank you, Dillal sir, for the great opportunity. So thank you very much. Thank you all.
Thank you, ma'am. Now I invite Dr. Aslam sir to present the certificate to Dr. Ashwan. I invite Madhav Nambiyar sir to present the memento and certificate to P. Rajan sir. I invite R.D. Vijamor sir to present the gift to Rajesh sir. I invite Srijan sir to present memento and certificate to Dinraj. Now the vote of thanks. Good evening everyone. First of all, I express my sincere gratitude to our senior-most faculty members. A special thanks to Dr. Rajesh sir for gracing today's program with his presence. It is truly inspiring that with just a single phone call, they are always willing to join with us. I extend my heartfelt thanks to Rajan sir for his inspiring talk, for sharing his wealth of experience with us. His practical wisdom and guidance will undoubtedly help us deal with the difficult clinical situations more effectively. I would also like to express sincere thanks to Dr. Dinraj, a young and dynamic surgeon who is doing remarkable work in the management of thoracic injuries. Today's session provided us with an excellent overview of current management protocols for chest trauma and highlighted that the management of chest injuries extend far beyond simply inserting the chest tube. Thank you, Dinraj, for such an enlightening and practical session. My sincere appreciation also goes to our postgraduate presenter, Dr. Ashwin, for his confident, well-prepared and well-delivered presentation. I would like to extend my heartfelt gratitude to our sponsors, ISIS Pharma, for their generous support in making today's academic program a success. Finally, I thank all our teachers, colleagues, friends and postgraduate students for your enthusiastic participation and wholehearted support throughout today's program. Once again, thank you all. Now I request everyone to kindly rise for the national anthem. Janagana mana adinayaka jaya he Bharata bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Banga Vindhya Himachala Yamuna Ganga Uchala Jaladi Taranga Tava Shubha Name Jage Tava Shubha Ashisha Mage Gahe Tava Jaya Gata Janagana Mangaladayaka Jaya He Bharata Bhagya Vidhata Jaya He Jaya He Jaya He Jaya 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 He. The meeting is adjourned for dinner and fellowship. Thank you. Good night.